talk here about the non-viral infections of the liver, which primarily manifest themselves as abscesses and cysts. So we'll briefly talk about the anatomy of the liver and biliary tract. We'll talk about the bacterial abscess or pyogenic abscess of the liver, the amoebic abscess of the liver, and then the Hydatid cyst, which is part of a wider disease known as Echinococcosis. So here's the anatomy of the liver. We've got the falciform ligament dividing the liver into the right lobe and the left lobe. There's more lobes underneath that you could talk about anatomically if you look from the inferior aspect, but we're not going to talk about that here. As far as vascular supply, we have the hepatic artery, which is ultimately coming off of the aorta, and so this gives rise to a right and to a left hepatic artery. This provides most of the oxygen for the liver. We also get oxygenation through the venous tract. So this would come through the portal vein, and the portal vein is made up of the splenic vein, inferior mesenteric vein, and superior mesenteric vein. They come together and they receive a few more tributaries, but they're then at that point the portal vein. Draining the liver, we have the hepatic vein, which we've got a right and a left. They come together, form the hepatic vein, and then ultimately drain into the inferior vena cava. So the bile tract, we've got bile coming from both our gallbladder and the liver. Draining from the liver, we have the hepatic ducts. That makes sense because the liver is hepatic. So we've got a right and a left hepatic duct draining the right liver and the left liver. Those come together to form the common hepatic duct right here. And then that becomes joined with the cystic duct, which drains the gallbladder. And when the cystic duct and hepatic duct come together and join, that forms the common bile duct. The common bile duct runs inferiorly towards the duodenum, but it hits up with the pancreatic duct, which once those two come together, the common hepatic duct and the common bile duct and the pancreatic duct, you now have the ampulla of Vater. And the ampulla of Vater releases into the second part of the duodenum. The sphincter controlling that is known as the sphincter of Oddi. Alright, so the pyogenic abscess of the liver is a relatively uncommon disease overall. However, as far as we're talking about abscesses of the liver, this is the most common entity in the U.S. So this is a localized bacterial infection of the parenchyma, as all abscesses are. And the classic clinical presentation of this are going to be your typical liver upset signs, so right upper quadrant pain, maybe radiating to the epigastric pain. Also, a lot of times, if it's on the right side of the liver, it's going to refer up to the right shoulder. And then you'll also have your more septic signs because you have a bacterial infection, and that can include fever and chills, and in the late stages, sepsis. Occasionally you can get jaundice. If the abscess is big enough, it can impinge upon the biliary tract, and so that can cause obstructive jaundice. Hepatomegaly is often noted on the physical exam. There are some patients who are at noted risk for pyogenic abscesses, and those are going to be patients usually with pre-existing liver disease. So primary sclerosing cholangitis, diseases of the bile tract, anything that increases your risk of cholangitis, cirrhosis, liver tumors, inflammatory bowel disease, immunodeficiency, which is going to increase your risk, especially also of not just pyogenic abscesses, but also fungal abscesses. And then anybody with recent abdominal infection, if you have a recent abdominal infection, that may have slightly seeded the peritoneum, and that can actually then spread to the liver. And then some of the non-modifiable risk factors just include advanced age and male sex. Now, 40% of the pyogenic abscesses of the liver are idiopathic. However, some of the common ways to get abscesses, one, like I already mentioned, would be like an ascending cholangitis through a biliary ductal problem. Another way you can get it is through pilophlebitis, which is infection of the portal vein. You can also get it through a general bacteremia from an infection somewhere else, and so it's spreading. Maybe you had an infection, you had dental work done, and you can actually possibly get an infection from that because you get seeding into your blood. I suppose that would be rare, but that would be a possible situation where you can get bacteria into your blood and then ultimately into the hepatic artery, and then it can get into the hepatic parenchyma from there. You can also get it from direct extension and then also from trauma. So how do we make the diagnosis of pyogenic abscess? We've got a patient coming in with fever and chills, right upper quadrant pain, disturbed liver labs, maybe jaundice. We're always suspicious about biliary tract problems, so we probably are going to do that sonography first, looking for bile stones, looking for problems with the biliary ductal system. We don't see any, but rather what we see is a mass. Of course, the initial thing that we're concerned about is cancer. However, when we look at the mass on CT, it's going to look a little bit different from cancer. So the best initial diagnostic test when you suspect a pyogenic abscess is going to be a CT. And usually with pyogenic abscesses, there's going to be multiple foci of masses. There may be one very large one, but there's multiple foci of mass, and that's widely in contrast to the amoebic abscess, which we'll talk about in a little bit. Some of the other things that can help you distinguish this from cancer, which may also have right upper quadrant epigastric pain and jaundice, are that with the pyogenic abscess of the liver, you can have increased white blood cells with left shift. And you also, of course, are going to have abnormal LFTs, low albumin, that just shows decreased albumin production in the liver. And the PT may also be high just due to general liver inflammation and problems. So this is a CT of a pyogenic abscess of the liver. You can see that there are multiple, maybe there's one major focus, but there's multiple abscesses here. And the abscesses are surrounded by a more whiter material on CT. So you get this sort of haloing of the abscesses, or walling them off. There's another one kind of like that. Again, you've got one big one and usually other small ones around it. This is going to be in contrast to the amoebic abscess, which we'll see often only has one. So what do we do for treatment? Pyogenic abscesses of the liver are always deadly if they're not treated, and the only way to treat pyogenic abscesses of the liver is through surgery. Now, in most patients, when they have symptoms of abscess of the liver, we may not be sure if it's pyogenic or amoebic. I'll tell you that 90% of them, or 80 to 90% of them, are pyogenic. It's very difficult in the United States, especially if you're practicing in a northern part of the United States, to get an amoebic abscess. Amoebic abscesses are something that are gotten more in tropical areas, Mexico, Guatemala, Brazil, Uganda. So most people in the U.S. who haven't traveled likely have pyogenic abscesses of the liver. And so we know that these patients are going to need to have surgery because that's the only way to treat pyogenic abscesses. So what we're going to do is resuscitate them for surgery, and the surgical therapy for them is a CT-guided percutaneous drainage where we drain the abscess of the liver. And that's the definitive treatment for pyogenic abscesses. In addition to doing that, we should get blood cultures on them, and then also place them on IV broad-spectrum antibiotics. You should always include metronidazole in your broad-spectrum, but you should also include something to cover gram-negatives. So ampicillin, gentamicin, third-generation cephalosporin, carbapenem, beta-lactam with a beta-lactamase inhibitor. Any of those are good choices. The reason that you want to include metronidazole is not just because you want to include some of the anaerobes, which metronidazole does, but because, let's say you weren't so sure if it was a pyogenic abscess or an amoebic abscess, as we're going to see, metronidazole actually covers the amoebic abscess too. And so you don't, that kind of gives you some insurance there. And then you'll also want to identify the underlying cause if possible. Now, patients who are immunocompromised may be at risk. They are at risk for mixed pyogenic fungal abscesses. Not all of them are going to have that, but some of them may, and you need to keep that in mind. And this is especially patients who have hematologic malignancies. So, in immunocompromised patients, we should definitely be making sure that they are responding promptly. If they don't respond to surgery and antibiotics, then you should add amphotericin B. And in patients who have hematologic malignancy, you may just start them on amphotericin B with the broad-spectrum antibiotics, just because the index of suspicion for them to have a fungal abscess of the liver is so high. Okay, the amoebic abscess of the liver is quite uncommon in the United States. Even among liver abscesses, it only makes up about 10%, and I would say in that 10%, that's probably from the very, very south part of the U.S., closer to Mexico. You should look on USMLE questions for a patient who has had recent travel, maybe exposed to the local water source, maybe an immigrant, migrant worker. But this is the most common liver abscess worldwide. And patients, like I said, with recent travel to endemic areas should be suspected for amoebic abscess of the liver. 20 to 30% of patients who have the amoebic abscess of the liver will also have a history of diarrhea, particularly dysenteric or bloody diarrhea. Why? Because the actual microorganism that causes the amoebic abscess of the liver is Entamoeba histolytica. And if you remember back to medicine, Entamoeba histolytica is one of your common causes of bloody diarrhea. So 20 to 30% of patients who have amoebic abscesses of the liver will actually be able to recall a history of diarrhea or bloody diarrhea, and that's just because the organism was in their intestines and causing a colitis. Not all patients are going to have a history of that, though. So amoebic abscess of the liver is just part of the many things that E. histolytica can do to you. The symptoms for amoebic abscess of the liver are pretty similar to pyogenic abscess, with insidious onset of fever, right upper quadrant pain, hepatomegaly, including jaundice, possibly if the abscess is big enough. But the one thing that stands out is both that the patient has been somewhere outside of the United States, more than likely, or is in that region closer to Mexico, or they have had this history of diarrhea, dysenteric diarrhea. Again, here for diagnosis, anytime a patient has right upper quadrant pain, we're usually going to do a sonogram first, and we'll probably find a mass. The best initial diagnostic test to do at that point then is a CT. Usually amoebic abscesses are singular. Routine labs should also include getting your CBC and CMP, which is just your blood, your BMP with your liver function tests. You should see an increase in white blood cells with a left shift, abnormal liver function tests, low albumin, PT may be high. This is just showing abnormalities in the liver, an infectious abnormality. So here's an amoebic abscess. I got 4 pictures of them. They're all on the same patient. And so this is looking from superior to inferior. And typically with the amoebic abscess, it tends to be just one locus rather than multiple loci. That's just a rule of thumb, though. That's not all of them. Okay, so if you were to pull out the cystic fluid that's inside the amoebic abscess, you would get what's called anchovy paste appearing material. And that's just what they call it. I've never seen anchovy paste before until I put this together, but I guess it kind of looks like what they would get. So anchovy paste material. Whereas if you were to do a bacterial abscess, pyogenic abscess, you would get pus, which we all know is really white, smelly stuff. So this is an ultrasound of an amoebic abscess. They can rupture. So you're always doing ultrasound first, but you shouldn't see this. You should just see a round mass. Okay, what do we do then for treatment? We have to ask ourselves a few questions. So if we're pretty sure that this is an amoebic abscess, meaning the patient has been recently to Mexico or to Brazil or to Ecuador or any of these tropical countries, then we are going to just place them on metronidazole and observe them. The exceptions to this are if the mass is greater than 12 centimeters, if it's questionable, if maybe they haven't been out of the United States, but they have some things that make it look like an amoebic abscess, some things that maybe radiologically look like a pyogenic abscess, so we're not really sure, or certainly if the mass is greater than 12 centimeters, or if we started them on the metronidazole under the assumption that they have an amoebic abscess and they don't respond to medical treatment within 5 days to a week. At that point, then we're going to do the CT-guided percutaneous drainage, like we would do for a pyogenic abscess. And at that point, then we'll be able to get a definitive diagnosis. Most of the time, it'll come back as an amoebic abscess. But it's important to keep pyogenic abscess on your differential in patients where you suspect amoebic abscess, and vice versa. For the USMLE, though, I can almost assure you that with the amoebic abscess, they're going to give you something in the patient's history indicating that they've been outside of the United States. The Hydatid cyst is extremely common outside of the U.S., but it is seen in endemic areas. So these areas are Southeast Europe, like Greece and the Balkans, the Middle East, South America, and also Australia. Especially those where sheep are raised, and usually you have to have some kind of contact with sheep or with dogs or goats in order to get this. That puts you at a higher risk, but really what we're worried about is the feces of those animals. And so that's how this is acquired, and this is a parasitic disease. This comes from a tapeworm called Echinococcosis granulosus. And the classic symptoms are going to be a little bit different from the abscesses that we saw before. This isn't so much fever, this isn't so much severe pain. It's going to be patients with risk factors who have this hepatomegaly, maybe a little bit of discomfort in the right upper quadrant area. This mass can grow to be actually quite big, and it can obstruct the biliary tree. Also, if you get a little bit of rupture, you can also have Hydatid cysts in other areas. The 2/3 of them are in the liver, but you can also have them in the lung and elsewhere. You can have symptoms consistent with urticaria and anaphylaxis. So another thing to look up for. So again, because these are patients with right upper quadrant pain or biliary problems, you're going to be doing a sonography first. The sonography is usually going to give you some suspicion based on the fact that you have some kind of mass in the liver. So the best initial diagnostic test at that point is going to be CT. When you're looking at the CT, it can be difficult to distinguish it from an abscess. One of the things that can help, though, is that with a Hydatid cyst, a lot of times you have a cyst, a very easily demarcated cyst, with daughter cysts in between. Sometimes you don't. Sometimes you see kind of like a little line in between it, but I'll show you some pictures. But one of the things that's very classic is for you to have a cyst and these little daughter cysts inside. In some cases, if you get a CBC, routine labs will show eosinophilia. That's only in about 10% of the patients, but that's very typical of the Hydatid cyst. The most accurate laboratory test is going to be serology for Hydatid cyst antigen. The problem is that that thing usually takes like a week or two to come back because you have to send it off. Treatment, classically, surgical removal of cysts and sterilization is the initial therapy of choice. However, in patients who surgery is contraindicated or who are older, treatment can be done with albendazole and mebendazole oral therapy. So here's a Hydatid cyst. I got multiple pictures here. So here it's pretty much taking up almost the entire liver here. The cyst is really massive. And you've got compression of the liver parenchyma up to the side here. But here's your cyst, and then here's your little daughter cysts, all nestled in together. So it's a little bit different than the other ones. But for the USMLE, I would rely on your history of the patient. Okay, and here's another Hydatid cyst. Remember what I said about that little line going through? This is another way you can see it. This is kind of like line that comes through. This is another way that echinococcosis can present up in the liver. But like I said, most important thing is to know about the patient's history. That's what's really going to distinguish these hepatic cysts from one another. Okay, so to recap, pyogenic abscess is the #1 abscess for the liver in the U.S. It can present with biliary issues, abdominal infection, sepsis, trauma, fever. Patient often has a history of cirrhosis. That puts them at higher risk. Their symptoms are going to be worsening fever, chills, right upper quadrant pain, hepatomegaly, jaundice, sepsis, increased white blood cells, abnormal LFTs. Diagnosis is on CT, and you treat this with percutaneous drainage under CT guidance and broad-spectrum antibiotics. Amoebic abscess, usually in their history, they'll have some kind of exposure to a tropical area. 20 to 50% will have a history of bloody diarrhea. Symptoms include pretty much the same as pyogenic abscesses. You'll also on labs see increased white blood cells indicating infection, abnormal LFTs. Diagnosis here, again, is going to be on CT. Treatment is going to be metronidazole, assuming that you are pretty sure this is an amoebic abscess and that this is less than 12 centimeters. If it's too big, it's at risk for rupture. That can be deadly. And so we don't want that to happen. So if it's less than 12 centimeters and you're pretty sure it's an amoebic abscess, you can go ahead and do therapy with metronidazole. Otherwise, then you're going to have to do the percutaneous drainage. Echinococcosis, history, exposure to endemic areas. Remember, like I said, Middle East, Southeastern Europe, Australia, and then especially exposure to sheep. Symptoms are hepatomegaly, right upper quadrant pain, sometimes biliary obstruction if it gets to be large enough. You can also have allergic symptoms, urticaria, and hypereosinophilia on labs. Diagnosis is going to be CT. However, the most accurate test is a serum test for the Hydatid cyst antigen. The treatment here is surgical removal, or it can be done medically with albendazole and mebendazole. And if you have a fungal abscess, which is usually an immunocompromised patient who fails to respond to a pyogenic abscess therapy, which is the CT-guided percutaneous drainage plus broad-spectrum antibiotics, then you'll want to add on amphotericin B to their treatment. Like I told you, though, if it's a patient particularly with a hematologic malignancy where their risk of getting a fungal abscess is way up through the roof, relatively speaking, you may actually just add on amphotericin B to their broad-spectrum antibiotics to begin with, just to treat that empirically. If you have any questions, let me know.